Okay, great. Well, thank you. Thank you all for tuning in and celebrating Pancreatic Cancer Awareness Month. This is really great. I know Melissa has put together a great group uh, of of physicians and scientists to talk about pancreas cancer. I did a quick scan and recognized a ton of you on the call, and hopefully this won't be too much of repetition, but. I thought I would run through a little bit on staging, treatment sequencing, a few comments on chemotherapy, radiation, and surgery. I know that we're probably going to have separate sessions on them as well. I think Melissa Beth Erickson did already talked about radiation, correct? And that was that Tuesday, or which day was that?
That was last week. Let me see.
Oh, okay. It was last week.
Last week on the 2nd, so Thursday.
Yeah. Okay. So I'm gonna talk about these topics. I would be thrilled to make it interactive. So if someone has a question, feel free to unmute yourself, and we can just attack it right then and there. And if not, we'll make sure that we leave plenty of questions to come at the end. So first, a couple words on staging. I think everyone is familiar with and we have a few YouTube videos on this as well, and there are probably others that people have done quite nicely. But staging is maybe the only thing, cancer staging is perhaps the only thing that the world agrees on when you think about it, because the world certainly doesn't agree on a lot of things, and the staging is 1 through 4, and every 4 or 5 years, the American Joint Commission on Cancer Staging platoons a committee to relook at the staging for most all of solid tumors, whether it be breast, lung, colon, pancreas. A number of years ago, I was involved for a few editions of the staging manual for pancreas cancer, and kind of dove deep into this. But the committee is charged with finding those factors that create the greatest difference in the survival curve between stages 1, 2, 3, and 4. So as newer treatments evolve and there are new prognostic indicators. So, for example, there's a tremendous amount done in melanoma and in breast cancer with a lot of the uh, uh, genetic analysis of the patient and the tumor and everything else that has been integrated into staging. That hasn't occurred yet in pancreas cancer, but we still have stages 1, 2, 3, and 4. And very simply, stage 4 means that it's spread to another part of the body. Stage 3 means that it's localized and usually not removable. And stages 1 and 2 are different size tumors that would in general be removable. The pancreas cancer world realized that stages 1 through 4 don't really apply that well to pancreas cancer. And therefore, many years ago, I think we first described what was called borderline resectable disease. Now, gee whiz, it would probably be in the late 1990s or around 2000, so a little over 20 years ago. So you'll oftentimes see in medical records, maybe in your medical record, or in videos and in writing, that pancreas cancer can be staged as resectable, borderline resectable, locally advanced, and then metastatic, and that is really more useful and used more commonly than the classification of stage 1, 2, 3, and 4, because with pancreas cancer, most experts feel that while surgery is not sufficient to cure the disease, most of the time it tends to be necessary. So the resectable and the borderline resectable and the locally advanced designations imply an ability or inability to surgically remove the tumor. So does that make sense with staging? Pancreas cancer is a little bit unique in that the 1, 2, 3, and 4 is not used as commonly as the resectable, borderline resectable, locally advanced, and metastatic. And I might just stop there to see if anyone has any questions before I dive into treatment sequencing a little bit. Questions that anyone has? So when I was a when I was a surgical oncology fellow back in 1989, I was working with a very talented surgeon at the time in Houston, and I saw a patient who a few months after an operation, and at that time the standard treatment was to operate straight away on patients with pancreas cancer, and then they typically would get radiation after surgery with or without some chemotherapy. Many of the chemotherapy agents and combinations that we use today were not available then. Anyway, I was in the cancer center, and I saw a patient after an uncomplicated operation, comes back a few months later, and it's clear that the cancer is back. So at that time, there was growing enthusiasm in patients with breast cancer and in patients with rectal cancer to give them chemotherapy in the case of breast cancer, and chemotherapy and radiation in the case of rectal cancer while the tumor was still in place. Something that now is done routinely for a number of solid tumors, but back in 1989, it was pretty uncommon if the tumor was localized to the organ where it developed from, as opposed to already being spread to other parts of the body. So when that patient came back to clinic after just a few months and the cancer had recurred, we said, well, gee whiz, why didn't we give this patient something to other than surgery first? And we actually wrote a clinical trial that involved a small amount of chemotherapy and radiation given prior to surgery, and then we did a series of clinical trials over a few decades, exploring new and different options for chemotherapy, radiation, and surgery in combination. And really, probably within the last 5 or 6 years, the world has made a fairly complete shift in the treatment of pancreas cancer to begin most all patients, and some of you may have been treated differently, and that's because there probably was a reason for this. But in general, in 2023, most patients with pancreas cancer receive chemotherapy first, regardless of what stage of disease they have. And that's, on one hand, that's a really good thing. I think we're treating a cancer that oftentimes has microscopic spread of tumor outside the pancreas. We're treating it with therapy that will treat the whole body fairly early. One of the potential unintended, maybe negative consequences of this is that patients may actually not really know what their stage is and what their goal of therapy is. They may their internist or family doctor will get the CT report back, and the CT shows a tumor in the pancreas. They may or may not have jaundice, where the tumor is blocking the bile duct. The gastroenterologist is critical because they can do a biopsy of the pancreas with an endoscope, right? The endoscopic ultrasound guided biopsy of the pancreas. And the gastroenterologist can also put a stent in the bile duct if the bile duct is blocked and the patient is yellow. So in many cases, the family doctor or the internist receives the report that there's a tumor in the pancreas. They send the patient to the gastroenterologist. Pancreas and bile duct obstructions are usually a fairly common referral for an interventional gastroenterologist, a gastroenterologist who does ERCPs, endoscopic ultrasounds, etc. So they're aware of the fact that the patients usually get chemotherapy first. The patient then will get sent to a medical oncologist, and oftentimes be started on chemotherapy. And in the absence of the patient being seen at a larger center where there is, for example, a pancreas conference. Here at our institution, we have a weekly pancreatic cancer conference every Friday morning that goes from 6:30 in the morning to 8 o'clock in the morning, and we discuss not every patient. We discuss our more complicated patients, but more importantly, it allows all of the doctors and nurse practitioners and PAs and everyone involved in the disease to talk with each other and gain consensus over how we manage patients, especially if they're not on a clinical trial. If they're on a clinical trial, how they're managed is usually very prescribed by the clinical trial itself. But in any event, the point I wanted to make is that now, and in fact, Gabby and Natalie and I do a number of second opinions, and because my clinic ran a little late yesterday, Gabby and I actually just finished doing 3 or 4 second opinion chart reviews, and one or two of those patients had been started on chemotherapy without really an end point, without an overall plan. And I just bring that up because it's something to be aware of for those of you who are patient advocates and are helping patients navigate through really an incredibly complicated area of cancer therapy right now. That I think the good news is that patients are getting chemotherapy sooner. The chemotherapy, as you'll hear from Dr. George or Dr. Mandana later this month, is much more effective. It's delivered with incredible skill, with a tremendous amount of care and compassion. But one of the unintended consequences is sometimes the actual staging of the disease is never really clarified, and therefore whether or not the tumor is operable is never really completely clarified, and because of that, it's never really clarified what the overall treatment plan is. So for those of you who know a fair bit about our program, one of the things that Susan Tsai and Dan von Hoff and Urquhart Borzanski and Beth Erickson, Bill Hall, Kathleen Christians, who I work with, everyone has basically, because we spend so much time together, one of the things that kind of characterizes our approach to treatment sequencing is what Susan Tsai has named an adaptive design to our treatment, and it's present in all of our clinical trials, and it's part of how we treat patients. And an adaptive design means that we assess whether or not the chemotherapy is working, and we try to assess that after about 2 months. So you can see one of the advantages of having, and there have been a couple trials that have looked at treating patients with surgery followed by chemotherapy versus chemotherapy followed by surgery. And one of the advantages of giving patients a treatment that is non-surgical while their tumor is still in place is that you can tell whether or not it's working. And you'll say, well, gee whiz, that's kind of common sense. But if you think about it for a minute, so a really special relative of mine, because I'm her dad, had melanoma during a recent pregnancy, and that's treated completely different than pancreas cancer. But the melanoma was removed, And then after the baby was born, she received a year of therapy that was targeted specifically at a couple mutations that were in the melanoma. We had no way really of knowing whether that treatment, whether if she has any remaining tumor cells in the body, whether those tumor cells were sensitive to the treatment. In that disease, I think we have pretty good evidence that the treatment is fairly highly successful against that specific type of melanoma that she had, just from hundreds and hundreds of patients who have been treated with that. In pancreas cancer, we know that the chemotherapy in patients who have more advanced cancer, the chemotherapy is the right treatment for the patient about 30 to 40% of the time. So if we assume that in patients with earlier stage cancer, their tumors are smaller. If there is spread in other parts of the body, it's tiny and therefore much more curable. If we say, for example, the likelihood that that chemotherapy is effective might be 50%, might be even maybe a tad greater than 50%. That means that there still are a large number of patients for whom that chemotherapy isn't the right choice. Correct? If everyone is following me, one of the huge benefits of giving chemotherapy first is that in most patients, we can at least obtain a signal after a couple months as to whether that chemotherapy is effective or ineffective. And if we think it's ineffective, we can then change the therapy. I think that's not something that is done universally across the country. But I think similar to doing surgery later in the treatment program for patients with localized pancreas cancer that we champion now 25, 30 years ago, I think the adaptive design where we try to figure out whether the chemotherapy is the right answer after 2 months rather than after maybe 3, 4, 5, or 6 months will also become fairly routine for patients within the next 2 or 3 years. Certainly, that's how we have our clinical trials. The advantage of staging the disease earlier on in the treatment program is the patient and their family will know whether or not the tumor is thought to be removable, may be removable, or clearly not removable. And therefore, the goals of treatment can be a little bit more clearly defined. So now I think across the country for patients with localized or metastatic pancreas cancer, chemotherapy is really the first treatment. For patients where the tumor is thought to be operable, resectable, borderline resectable, or to include a subclass of patients with locally advanced pancreas cancer, and how we stage the tumor based upon the tumor and the blood vessels is a little bit complicated. I tried to discuss this in a YouTube video, and if you go to Pancreas School, you can watch a couple of the Pancreas School YouTube videos, and hopefully the staging makes a little bit of sense. And the general paradigm that we have in most of our clinical trials is roughly 4 months of chemotherapy, then radiation, and then surgery. And I think Dr. Erickson talked a little bit about why we feel that radiation is still an important part of the treatment program. Chemotherapy, not controversial at all. Surgery for patients who have operable tumors, not really controversial at all. Radiation therapy remains a little controversial. And that's largely because of a couple trials done in Europe, and then one tiny little trial done in the United States where a benefit was not clearly demonstrated. But in our opinion, and we've published a number of papers on this, radiation is still very important. So starting on chemotherapy, regardless of stage of disease, obviously very completely logical and appropriate. We would emphasize the importance of patients and their families getting clarity from their physician team on what their stage of disease is, on what their planned overall treatment program is, and what the ultimate goal of therapy is. Is it to remove the primary tumor? Is the primary tumor not removable? And if not removable, what would the overall treatment plan be? And then, as mentioned, we tend to advocate reassessment at 2-month intervals with an eye towards determining whether the treatment is working, not working, whether there should be a pivot and a change in therapy. So I might stop there for a couple minutes and see if there are any questions, and then go on to maybe another little topic. Any questions on sequencing? Anything not make sense at all?
Looks like we have a hand raised. Mr. Hussein.
Hi, Dr. Evans. I think one of the questions going back to the earlier part of your talk is around staging, is how relevant is the borderline resectable stroke locally advanced distinction. I know in my case or in others, it's very much in the eye of the beholder when it comes to locally advanced and whether surgery can be performed. And I know it was an issue for me, but is this a bigger issue widely in these second opinions that you look at? Do you often see cases where you take a different opinion to another surgeon or doctor?
Yeah, I mean, couple things, and good to talk to you, and thanks so much for dialing in. So we're blessed to have a very talented radiology department here in Milwaukee. As some of you may know, General Electric Healthcare is a Milwaukee-based company. So most of the CT scanners in the United States are made in Milwaukee, Wisconsin, if you can believe it. I know that you mostly think about Milwaukee as a place of Harley Davidson and Northwest Mutual and Mercury Motors, but GE Healthcare is here as well. And so the radiology department here has always been very interested in imaging of the abdomen, especially the liver and pancreas. And what we have tried to do, and this goes back to even when I was in Houston at Anderson, and a couple really smart medical oncologists, Bob Wolf and Gauri Varadachari, were behind this as well. We said, this staging, there's no need for it to really be subjective. If the surgeons can tell us what they feel they can do, assuming that the patient is healthy enough, and I'll get to that in a minute, but if the surgeons tell us what they can do, then you shouldn't really need to have a surgeon to determine the stage of disease and whether the tumor is operable. And that was something that we began really championing probably now around a little over 20 years ago. And it still is somewhat misunderstood. So if you joined us for a Friday pancreas conference on Friday mornings, you would see that the radiologists stage the disease, and just because we spend so much time together, that they know what we can do from a technical perspective, which blood vessels can be removed and replaced, et cetera. And there's an occasional situation where it's really complicated, and so we begin to exercise a little bit of judgment. But in general, we try to use a very objective anatomic staging classification for what is removable or operable and what isn't. And the operable tumors they could be resectable, they could be borderline resectable, or locally advanced type A in our within our system. So we try to make that objective. The other misconception that I think is very common is that with chemotherapy and radiation, the operability of the tumor may change. That's very unusual. If the tumor is sensitive to the chemotherapy, then the tumor may decrease in size. So it may go from I don't know, it may go from say $50 down to a quarter in size, but usually the relationship of the tumor to the adjacent blood vessels doesn't change, despite oftentimes an excellent response. So what we see sometimes is that patients are begun on chemotherapy, and their treatment team will say, well, if there's a response, then it may become operable. And I just disagree with that. I think that is a very rare phenomenon. Occasionally, at the time of diagnosis, there's a fair amount of inflammation in the pancreas. And when we see dramatic responses to just 2 months of chemotherapy, for example, it's usually that the inflammation has gone down. But in the majority of patients, even when they have a great response, the tumor gets smaller. So the diameter of the tumor goes down, but the relationship to the blood vessels doesn't change. The operation that is needed to remove the tumor doesn't change. And that's why I think accurate staging can be done at the time of diagnosis. It could perhaps be refined a little further 2 months after diagnosis, after the first 2 months of therapy. But it's unusual for a decision on operability to change over time. The reason we give chemotherapy and radiation prior to surgery are 2 fundamental reasons. Number one, pancreas cancer spreads to other parts of the body frequently. And oftentimes you can't see the tiny little micrometastases. So we know from days gone by when we operated on patients straight away, and then either did or did not give them something after surgery, that the cancer came back about 90% of the time. So if you just extrapolate that to the present, we know that if we see a patient today with newly diagnosed pancreas cancer and it's localized to the pancreas, there's probably about a 90% chance that there are microscopic tumor cells at way beyond the level of detection. They're not going to be seen with any X-ray test or PET scan, they're not going to be seen with anything. They're microscopic, but we know that they're present either in lymph nodes, in another part of the body, in about 90% of patients. We know that the number of resistant cells in a tumor location is based upon the number of total cells or the size of the tumor. And that's why pancreas cancer it is more curable when the number of tumor cells is smaller. And that's why now our results with chemotherapy, radiation, and surgery are so much better than they were historically with surgery, with or without anything else, because the chemotherapy and the radiation can in fact cure microscopic spread of tumor to lymph nodes or potentially to other parts of the body. So that's the reason that we give chemotherapy prior to surgery. The reason we give radiation is that the pancreas was put in a crummy place. God was just having a bad day when the pancreas was inserted. And we can't take out a lot of soft tissue around the pancreas. And therefore, if we can at least sterilize the periphery of the tumor, then we can decrease the risk for the cancer to come back locally, right where the pancreas existed. Obviously, nothing is 100%, but that's a strategy that we use to try to reduce the risk of recurrence.
Thanks, Dr. Evans. We do have a couple questions that are in the chat box, and then also it looks like John's iPhone is raising his hand. So John, if you want to go ahead and ask your question, and then I'll follow up with what's in the chat box. John's iPhone. You want to go ahead and ask?
Yes, I don't know if you can you hear me now?
We can hear you now.
Yeah. Well, thank you for taking my call, and good evening, Dr. Evans. I don't know if you know all your patients, but I've talked to you 2 or 3 times during my journey. I'm a Detroit Lion fan, and my condolences with your Green Bay Packers, but there's always next year.
Yeah. Well, it's nice of you to get that in there. Yeah.
Well, there's not too many years you can with this team.
Oh,
so.
yeah.
But doctor, I'd ironically, I had gotten a second opinion from you and was on FOLFIRINOX for 4 weeks or 4 sessions. And we took a look at it and it wasn't responding. And I think Abby was, I was working with Abby on that too. Your suggestion was to switch over to Albaxtrine, and my tumor went from like 2.8 to 2.0. So a significant response. I did go ahead and have the surgery, and I've been, I don't know, cancer free, they say, for 14 months. My latest CAT scan was on the 27th. But I'm concerned, and I did have follow-up chemo with the same Albaxtrine because they said it seemed that, it had a clinical response. I didn't hear, and I got on a little late, I didn't hear you advocating or speaking any about post or adjunct type of chemotherapy.
Yeah, I mean, so if we give patients in many solid tumors, you bring up a great question, and I'm thrilled you're doing so well. In many solid tumors, if you add chemotherapy with or without radiation to surgery, and the surgery removes the entire tumor in whatever way you give it, many doctors in the oncology field feel that the amount of chemotherapy and radiation needs to be in the range of like 6 months. So if we have a patient who receives 4 months of chemotherapy, then receives radiation, usually with the chemotherapy, but not always, and then surgery, we have termed that a total neoadjuvant approach. In other words, that's a complete therapy. So the question is, should the patient then get additional therapy on the back end or additional adjuvant therapy after that? And, I'm glad you brought that up because we have a clinical trial that will open very soon. It just went to the IRB, and it's supported by the Sina Mangowitz Foundation, and was really one of the big reasons why Roger Mangowitz and his entire team came to Milwaukee this past summer, and we did the very successful fundraising event at American Family Field. And this trial is for patients where either the pathology or the lab tests after surgery are not exactly what we would want them to be. So we hope that with chemotherapy and radiation, that when the tumor is taken out, that the surrounding lymph nodes and the surgical margins are negative. There's no cancer in them, but sometimes there is. I mean, this is under the microscope. This is microscopic. So for those patients, and for patients whose tumor markers or circulating tumor DNA still would suggest that there are cancer cells someplace, we're going to open a clinical trial just for them. I think right now, what happens in those situations is really just best physician judgment. And patients would either get additional chemotherapy. Some patients may get what we call targeted therapy, which are drugs designed against the specific genetic mutations that are in the tumor. Because nowadays, most tumors are sent for molecular profiling, very similar to the Know Your Tumor program that PanCan has. We happen to use the same company that PanCan has, and routinely send the tumor for profiling. So right now, whether or not someone would get additional treatment after the 4 to 6 months of chemotherapy and radiation and then surgery would be based upon those factors: the pathology report, the blood tests, etc.
Understand. One, if I'm can be allowed one follow-up question. I know there's other people here.
Sure.
And I may even reach out to Abby and you again, have you what's your record? Will you do third opinion sometimes, or is your record?
Well, especially for a Detroit Lions fan, we'll do anything.
I unfortunately received a CAT scan results today that showed, and I'm not going to get too far into weeds with mine, but it showed, thought I was doing good, 14 months. I had a scan on September the 27th. Well, I had another one, mostly because of scan anxiety. And it showed that there was a slightly increased narrowing of the silic and common heptic arteries. And it's minimally compared to the 27th. But they said it was, although these findings can be seen as fibrosis, the increased vascular narrowing and increased new appearance since March 14th raises concern of local reoccurrence. Correlate with C19. My C19 has been insensitive, I guess, for the word. It's always been 0.2, Doc. In this last one, it was 5.9, which is no big number, but I didn't know if
I think I would be more than happy to look at the scan, and I suspect your doctor is probably going to order a PET scan. This is a situation where I think a PET scan would be quite helpful.
Okay. Yep, that's what he's doing. So I appreciate the feedback, and
sure.
Always next year for those Packers.
Yeah, well, good luck to you. Good luck.
Thank you for that. Okay, one of the questions we have is, let's see, from Deb. Did you do your residency at MDA in Houston? And then she said she sees Dr. Katz there, and he did her Whipple in June of this year. And Dr. Katz said he will not stage for cancer at all. Is this common?
Yeah, I did my fellowship there. I did my residency at Dartmouth, did my fellowship at MD Anderson, and then I stayed there for about 18 years or so. So Dr. Katz was actually one of my fellows. So I know that he did a good job with your surgery, and I think I can't comment on the staging situation. I mean, we usually stage the disease at diagnosis, and that is very helpful and very important for us in running clinical trials. We try to put as many patients as we can on clinical trials. So obviously we need to know the extent of their disease in order to interpret the outcome at the end of the trial. So you could probably reach out to Matt or his nurse practitioner or PA, and I bet they would be happy to stage your disease at the time of diagnosis. And I'm thrilled that you're doing so well.
Great. Our next question from David: is staging a predictor of survival?
It is associated with survival, and it's also associated with the likelihood of completing all intended therapy. So if you start out day one, the likelihood of completing chemotherapy, radiation, and successful surgery is the highest for patients with resectable tumors. It goes down a little bit in patients with borderline resectable tumors because there's more cancer there. And it goes down a little bit further in patients with locally advanced tumors. So that's where, and with an individual patient in the office, I usually get into the weeds a little bit more with them and share some exact numbers with them. But it also provides them a clear understanding of what the goals of therapy are.
Great, thank you. Another question: would you enroll a patient in a clinical trial if they were eligible over the standard of care chemo treatment plans?
Yeah, thank you for asking that question. That's a great question. Here at MCW, we have two types of clinical trials. One, the clinical trial that we developed, so we would refer to them as investigator-initiated clinical trials. So we thought up the idea, with or without an investigational drug that was negotiated with the drug company. And then there are cooperative group and industry trials, which may also be open at another institution. But we decided as a group to open them here. We would never open a clinical trial within the pancreas program, and we're a very close-knit group of us. We would never open a trial that we wouldn't enroll in ourselves. So, and I think that's true almost everywhere. So, and you can, if you have any questions, just ask your doctor, would you enroll in this clinical trial? I mean, and I can tell you that any clinical trial for pancreas cancer that's available here at the Medical College of Wisconsin, we would sign up for ourselves if we had pancreas cancer. We believe that it represents the potential to be better than standard of care. The other thing that's very valuable about a clinical trial is that along with the clinical trial comes research nurses. And for those of you who may have gone to a Catholic school or had kids that went to a Catholic school, I mean, the reason my son is as successful as he is today is because, the nuns absolutely beat him up in middle school. And it was critically important for his development. It was probably a tremendous amount of physical abuse, but it made him what he is today. Well, the analogy I have to the research nurses is they don't tend to beat the doctors up, but nothing gets past them. Just like the nuns at my son's middle school, he could never get in trouble because they were one step ahead of him all the time. If you're enrolled in a clinical trial, the research nurses, the doctors, the nurse practitioners and PAs, you have a tremendous redundancy in the number of people who are looking over your treatment, and it provides a level of safety, which I think is kind of a little bit of a secret. It's unfortunately too good of a secret, but it provides that level of safety because you have so many people looking over your treatment to make sure that the T's are crossed and the I's are dotted.
Thank you for that. Another question, are there any clinical trials which are appropriate for patients whose pathology after chemo and surgery indicates clear margins and no lymph node involvement?
The clinical trial that will be opening up very soon and supported by Sina Mangowitz would enroll a patient with negative lymph nodes and negative margins if their tumor markers were elevated, or if there was evidence in their bloodstream for circulating tumor DNA. So it would require some signal that everything wasn't perfect. If their tumor markers were not elevated and their Signatera test was negative, then we would not give them any additional therapy. And again, we're doing investigations which are not standard of care. We're trying to bridge new territory and look for new opportunities to improve outcome.
Thank you. Any other questions? We have time for maybe one more.
I have a question. Hi,
Yes.
this is Lynn.
Hi, Lynn.
How are you?
Good.
Thank you for being here. My husband just started a clinical trial here at Mayo in Arizona. It's onvansertib. Have you ever heard of that?
How do you spell that?
ONVANSERTIB. It's apparently a new drug from Cardiff Pharmaceuticals.
Oh, sure. Yeah. I would have to refresh myself on the name of the drug, but that's the excitement that represents cancer care right now, is that new therapies are being developed every month. I mean, it's just it's an explosion in treatment options right now.
It's amazing. It's amazing. He was offered the standard of care or the clinical study or the clinical trial, and his CA19 was up to like at one point 81,000. And now it's down to 61, I believe. So to me, that means it's going in the right direction.
Oh, absolutely. Totally in the right direction.
Okay.
Yep.
Okay. How do I know it's going to continue in that direction? Because the original chemo was going in that direction, and then for some reason it just stopped.
Yeah, the cancer cells can be tricky. They can, you know, with the pressure put on them, they can sometimes develop additional genetic alterations that allow them to develop some level of resistance. So they can be very tricky, and that's why after a couple therapies, it becomes the art of medicine just as much as the science of medicine. So, you know, I suspect that your husband has a really good doctor, and you know that's where you rely on the physicians to exercise good judgment and to know when to pivot and make a change, and when not to, when to take a treatment break. And you know that's the importance of having a doctor or a doctor team that you're really happy with.
Right. Well, yeah, we just got nervous. It started in March. It was at almost 50,000. And then it went down to like 48,000. Then it went down to like 31,000. And then it shot up to 81,000. So that's when they stopped and said no longer working.
Yeah. No, I think everyone would agree with that. Absolutely. Well, I hope things work out, and I hope this works.
We're going to come for a second opinion to you.
Well, would be happy to see you.
Thank you, sir.
Thank you. All right, everyone. Thanks so much for joining us tonight. We do have another lecture tomorrow. This will be CJ Christians. He's one of our genetic counselors at MCW. Next week, we'll have a couple lectures as well, Tuesday, Wednesday, and Thursday, starting with nutrition with pancreas cancer, with Michelle, our dietitian. One of our radiation oncologists, Dr. Bill Ho, will be also talking about understanding the importance of radiation therapy next week, Wednesday. And then our medical oncologist, Mandana Kamgar, will be talking about what is pancreatic cancer. And then the following week, we'll have Dr. Tola and Dr. Stephanie Vincent Sheldon, who will be talking about imaging of pancreas cancer and interventions related to pancreas cancer.
Great.
All right. Thank you so
Melissa,
much, everybody.
thanks so much.
Of course.
Yeah, thank you all for tuning in, and I think we have a tremendous lineup. So please feel free to join. I think it's just Melissa has put together an amazing lineup, and good to see everyone, and have a wonderful Thanksgiving.
Thanks, everybody.
Thank you very much, Dr. Evans.
Thank you.
Do you see it?